If there are colleagues standing at the back, there are lots of seats on this side of the room. Please feel free to move forward if you would like as I introduce David Levine, our second keynote speaker. David is President and Director General of the Montreal Health and Social Service Agency in Quebec. I've known David myself for a number of years, and I'm sure you'll be fascinated by his presentation, the work that he and colleagues are doing in Quebec. David.
Thank you very much, Chris. It really is a pleasure to be here today, talk to you about a case study we're doing in Montreal. Little anecdote, left my hotel yesterday morning, walked along the street and found these bike stands. And I said, that's a great innovation. It's going to bring health and lifestyle to the people of London. I hope lots of people are losing these bikes. So I stopped somebody at the corner of the street and I say, what do you call the bike? What's the name of the bike? And he said, well, it's a Barclay bike. I said, no, it can't be a Barclay bike. Those are the people who announce on the bike. Who's the bike? And then they said, well, it's just Boris's bike. And I said, who's Boris? And Boris is the mayor of London who brought this in. And I said, well, do you know where these bikes come from? And they said, no. I said, do you know where they're made? And he said, no. And I said, well, the bikes come from Montreal. They're designed in Montreal. They're made there. They're called Bixies. And I took out my Bixie key, tried to put it into the stand here, and it wouldn't work. So I have a great suggestion between the mayors of our cities that they make our keys international, and when someone with a Bixie from Montreal comes to London, or London to Montreal, he can use the bike, which is a great way for tourists to enjoy the city. Just a slight comment. What I want to talk to you a bit about this morning is what we call now an accountable care organization, and a little bit about meaningful use. And I'm going to bring telehealth and telecare into these concepts. New concepts coming out, mentioned yesterday. Meaningful use is to ensure that the IS systems we're using are giving us really good use, and that accountable care organizations really integrate care and take care of the individual in a continuum. If we take a look at the province of Quebec, you have a huge territory in which the population, which is about 7.5 million, all live along the St. Lawrence River, Montreal being the largest city in the province. On the Montreal Island, we deal with about 2 million population. My role is CEO and president of the Montreal Regional Health Authority. It's the same thing as a strategic health authority, except this strategic health authority also is a PCT for the whole island. So we receive all the funding from the government by contract, $6.4 billion, and we administer all of that funding to the health and social service offering on the island to those 2 million population. So what I'm going to try to present to you is how do we manage that whole population, and how do we use telehealth and telecare, and how are we going to be using it to really better intertwine the offering of services and the population we serve. There was a health reform in 2004, 2005 in the province of Quebec. That's when accountable care organizations were developed. The objectives were very clear: improve the health and well-being of the population. This mandate had never been specifically given to a legal entity, to an organization. And by law, this mandate is now given. So there is a responsibility for the health and well-being of the population, which requires measuring the status of health of that population and improving it in a coordinated way. The next was bringing services to the population. So when we talk about telehealth, telecare, and bringing service into the home, that became one of the objectives of this reform and was clearly defined by the government. We want to facilitate use of services, involve the patient, and allow the patient or the client to be able to better access the care they need. Manage care of vulnerable clientele. There was a decision made that if we could manage the vulnerable or chronically ill person, we would be able to significantly reduce cost in the whole system. So there was a province-wide decision made that that was where the focus should be. And that became very important because telehealth, telecare is going to be an important component in managing the chronically ill person. Improve quality of care and cost. Went to a population responsibility, so the island of Montreal, about 2 million population, was divided into 12 networks. Each network was population-based, anywhere from 170 to 200,000 population, and that network became the legal entity responsible for the health and well-being of their population. Quebec was divided into 95 health networks. Obviously, the largest are on the island of Montreal. And then there was the concept of the hierarchical provision of services, a clear understanding of what is the tertiary, quaternary role in the system and what is the primary, secondary role in the system. The message here was move as much as you can out of the hospital into the community. We are and have been a hospital-based system for many years, since 1964 when the Hospital Act in Canada was brought into place, and 1969-1970 when Medicare was brought into the Canadian system. And we have been a hospital-based system because all funding of government is to patients in the hospital. It's been very recent that there's been any funding to patients outside the hospital. So this is a significant change in the Canadian environment. These health networks, what we did is we integrated hospitals, long-term care services, rehab services, home care services, primary care services, community groups, and the offering of services into one legal entity, one CEO, one board, responsible for all delivery of care, including social services to the population, dealing with the itinerant population, issues of prostitution, mental health, the full gamut of all services in one single organization, led by one CEO, one board, the board coming from the community as well as a number of professionals on that board. And that's the basis of the way we deliver care. Just picture the island of Montreal. Those are the 12 networks. On the island of Montreal, you have some significant differences in the nature of the population. The yellow zone, one example, per 1,000 births, you'll only have 17 births, 16 births for women under 17 years of age. If you take a look at the purple in the center of the city, you'll have 57 births to women under 17 years of age. And everyone knows that a birth to a woman at that age has significant more difficulty succeeding, whether it's in school, whether it's in their healthcare situation. Those are significant differences in the population base. Each network is responsible for their population, knowing their population, and adapting their services to the nature of that need. We sign a contract with each of the 12 networks. I provide funding to each of those networks, and we measure productivity and quality of care. The quality component is not up to where we'd like it to be. It really is volume measurement at the moment. What was the mandate of one of these networks? Manage and evaluate the care and well-being of the population, manage the use of services by the population, manage the services offered, so you have to actually manage the hospital and make sure it's well managed. But because the hospital and home care are now part of the same organization, the continuum of care between them and the physicians in the hospital and the link to the home and the physicians in the community are now much better integrated. We haven't yet changed the culture of all those physicians. So this has been going on for the last 5 years. It's going to take another 5 years before everybody culturally changes to start to work together much more closely. The local network in each of these population-based networks, the responsibility of the center is to connect with the municipality, is to connect with all the schools in the school system. We provide the nurses in the school. That's part of the healthcare service. In social housing, we provide the home care in the social housing. So all of that network has to be coordinated and connected together. Okay? So that's the basis of the system that I am working in at the present time. We developed a vision with each of the 12 networks on the island of Montreal. And the reason I'm mentioning it to you is as a lead into that Telehealth, Telecare project that I'm going to be presenting, and why it fits well within the vision of what we're trying to achieve. First of all, we said we have to develop a managed care model, managing care. If we can do that for the chronically ill, if we can do that for mental health, if we can do that for the continuum of care for the elderly, those three clientele, we will have significantly changed health care as we know it today. And it really is managing not the patient during the 5-6 day stay in the hospital, but managing the individual from birth to death. So we have to get the individual to sign on and to know how to manage their own care. The second element was the development of the multidisciplinary team primary care base, which we did not have. I think you're much farther advanced in England with your primary care teams, with your PCTs. You have a primary care vision. We don't. It is being developed. I now have 54 primary care teams on the island of Montreal, and our basis is that these become the medical hubs, and they are each responsible for 30,000 population on the island. We need 60, and it is out of these teams that all care begins to be managed. We need a unified and computerized medical health record. None of this can happen unless we have that unified medical health record. And that became one of our first steps. I'll explain that to you in a moment into what we did. And the fourth element of the vision is really empowerment of the population and the individual. If we don't empower the population, I think that was mentioned yesterday many times, we're not going to be able to reduce cost, because we're going to still be providing everything we do. And if the population doesn't do the take-up, then we are not going to be able to change the level of healthcare that we are offering. I won't go into the results. This data will be available to you. It would take me too long. There are 5 years worth of results of the project. You can read about them, what we succeeded in, what we didn't succeed in. There have been a great many successes in the type of care we are now offering. That wasn't the objective of this particular presentation. What I want to talk more about is the introduction of IT into the system and the move to telehealth, telecare as one essential component. We needed to find ways of improving quality, reducing cost and efficiency. That was clear. We believe the electronic health record is the key to that. Telemedicine became a real focus, certainly in a province as large as Quebec, to be able to introduce diagnostic ability to a large part of the province that doesn't have appropriate medical coverage. So you can see there that there is a real interest. And so the telehealth component from a diagnostic point of view, similar to what was just presented this morning, is very much in the forefront. Now this is distinct from the home care component, which I'll talk about in the moment. And that was the first part of telehealth that was introduced, because when you have a large territory and very little coverage, you need to be able to provide diagnostic services. And that was the first stage. I think that's well implemented. The technology is there, and we have some very, very good coverage. Our university teaching hospitals all got involved. Province of Quebec was divided into sectors. Each university teaching hospital component was given a sector of the province to be responsible for. They made all the links in the telemedicine hookups, and we have some very good coverage in that area. There's the whole issue of remote patient monitoring, and we've had our discussion of that this morning as a key in integrated care, and obviously the deployment of the patient electronic health record. We need to enhance the health network infrastructure. It is at its infancy. It really is. And though I think they're farther advanced in certain areas in the United States, that infrastructure is not yet in place the way it needs to be. We also needed to introduce hospital infrastructure, a wireless infrastructure. I think M-Health as opposed to E-Health is going to be the real solution, and it is going to allow us to do things that we never thought were possible previously. The major change I won't go into that. The major change of what we wanted to do in the Montreal project was to access to results from the patient, so that's anytime, anywhere, any place, to get clinicians informed so they can improve the quality of care, to ensure patient safety. Patient safety is a very big issue within the Canadian healthcare and Quebec healthcare environment. I think the same is in the States and here. And obviously the issue of significantly reducing cost. How did we go about this? Well, the first thing we did is we took a look at what is our IS platform within each of our institutions. So on the island of Montreal, I have the 12 networks. I have 8 teaching hospitals that are not integrated, and a number of specialized institutions that deal with issues of intellectually handicapped clients, that will deal with issues with physically handicapped clients. So how did we connect all the players? And we decided to go with one uniform platform for the whole island of Montreal. Got together with a firm, a large communications company in Canada, TELUS, that purchased from another company called Emergis that had developed a product called Oasis. Oasis was a IS platform that was initially put into our 2 major teaching hospitals on the island of Montreal. Both of these hospitals were going into a new build, each being a private-public project. We call them PPPs, $3 billion each. Both of them are in the process of being built at the present time, and included in that project was a complete revamping of the IS system in both of those institutions that have one chief information officer. What they did is they went to a single IS platform called the Oasis platform, which allowed to integrate all data into one common viewer. I took a look at that, discussed it with the other institutions on the island, and we decided to do a rollout to the whole island of Montreal. So every single professional and physician will look at the exact same screen, see their data in the exact same way, and then we will interconnect all of the institutions to access the data. And that hopefully will then be extended to the whole province on different platforms. It's only Montreal that's going on this particular platform. The advantages of this were significant for the whole city. It's being implemented at the present time. Obviously, there's a cost advantage because you go to a single platform. There's an education advantage because all the physicians, professionals are working on the exact same platform, and that has become really the core of what is going to integrate all the pieces of the puzzle. Now, I won't go into that. What did we do in the telehealth and the surveillance at home? Well, one of our 12 networks, the network out at the East End on the island, they really came to me and said, we'd like to implement a telehealth program at the home. What we're looking at is patients discharged from our hospital and the type of follow-up that our nurses do for those patients at home. And can we change the way our nurses interact with patients at home? And could we design a model that would allow us to collect the information and reduce nursing visits? So it was a very specific focus on why this network wanted to implement this particular type of program. In Quebec, telehealth at the home has been introduced since 2004. The first place it was introduced was for pulmonary obstructive disease out of a major hospital, teaching hospital on the island that was responsible for all of oxygen therapy on the island. So we gave that responsibility to one organization, and the patients that they follow at home on oxygen therapy were hooked up to a telehealth program in 2004. Okay, so that was the very first utilization. And since then, utilization has been very sporadic. And the reason, the cost. The cost was the real barrier to implementing this throughout the various networks either on the island or off the island. So there were a number of pilot projects, but it was very difficult to justify the investment for the return. And I think that is going to be the real issue with the use of this technology. Very excited about getting the results from yesterday morning, and I'll be looking for those results as soon as they come out to try to justify more investment in this particular area. But I think we've shown in the particular study I'm going to present to you that there's enough of return on investment that will allow me to move forward to cover the whole island of Montreal. So the context is an elderly population. This particular territory has 210,000 people, 30% or more chronic illness of one type or another. What we're really looking at is the 5% of chronically ill that are known. So of a 200,000 population, we have about 100,000, we have about 10,000 people that we're looking at. It's that group of 10,000 that I want to be able to roster. We want to be able to follow, have an integrated care plan for those 10,000 people in which most of the work is done by the individuals themselves, the empowerment of the individual. And the key question came, how do we involve the individual in their own care? And can we use telehealth as the tool to really involve the individual in their own care? Because what you'll see is we can't keep telehealth in the home permanently. It's an in and out exercise. And I'll explain what I mean by that, because the cost of keeping it in the home permanently is something we cannot sustain. So we want to have, we wanted to deal with increased demand for home care. On the island of Montreal, we do 60,000 clients per year. We do about 2 million home visits per year. Spend close to about $181 million. There's announced today in Montreal to increase that sum of money because home care is becoming more important. But you see that we take care of 60,000 patients per year on the island out of a 2 million population. And those patients have an average length of stay in the home. Okay, I mean, they're not permanently there because a lot of them are acute patients that we take care of in the home as well. Some patients stay on the program for a number of years, certainly care for the elderly that we're trying to keep out of. Now, this is both the social care at home and the health care at home that we are responsible for. Okay? And what we're very concerned about is the poor compliance and management of chronic illness, certainly the poor compliance to taking medication. That is a real focus of our concern. So over the objectives: to improve accessibility and continuity, keep the elderly at home as long as possible, develop the autonomy and empowerment of chronically ill people. That is really the focus, the empowerment. Reduce the number of home visits. That became our unique measure of cost in this particular study. Okay? Work as a multidisciplinary team. So we were using this program to bring the physicians, the nurses, and other professionals together to work as a team, because multidisciplinary teamwork is not yet implemented in an appropriate way in certainly the Quebec and I think the Canadian model. The last one was to use common protocols for chronic care. What we wanted to do by using telehealth is the fact that telehealth came with protocols, is that all our nurses would get on the same protocols. And at the moment, throughout the whole city, there are so many different protocols that there is no agreement, quite honestly, about the care paths that, or the care plan that each patient should have. So this was a way of coming forward with a common protocol that we could use. In the program, there's the user. This is with one or more chronic illness linked through a telephone or web connection to a group of professionals, as we've been speaking about since yesterday. There are the professionals, which are the multidisciplinary team, which is being created, collecting patient data, obviously on their computer. They provide the personalized care plan, that's the protocol, and we are now developing uniform protocols, collecting the data from the patient, and then the key is the permanent link, giving the confidence, giving the feeling of security, of safety to the patient. The benefits of the program: clinical protocols, as I've mentioned, electronic data acquisition, integrated medical record to Oasis. Because we have the Oasis platform, we integrate all of this data into the platform of Oasis that exists throughout the city, so that all of this becomes integrated and transferable. There's the medication management. So the conclusions. Study was done 2009 of the project. Very high satisfaction of patients and professionals. That was one of our first interests. Are people comfortable with this? Do they like it? Are they satisfied? Very high satisfaction. Nobody wants to give it up once they've got it. That was basically the end result. New technology easily accepted by patient and staff. So we had the question yesterday, is this technology accepted? Do people go along with it? Are they frightened by it? Is this going to be too intimate? Is Big Brother watching me? And what we got was that the new technology was easily accepted. This allows for systematic follow-up. Okay? It was an excellent, excellent learning tool. And that's the empowerment component. And it increased in patient self-management skills had been demonstrated. So there were questionnaires given to patients as to how much they knew about their illness, how much they knew about how to take care of themselves, what were the key things that they needed to look at, and it was demonstrated that there was a significant increase in patient management. What's the program? The program at the moment is 120 stations in the east end of Montreal that are being used at the present time. There's a 4-month length of stay. Average age of our patient is 82 years of age. Now, obviously, it's an elderly clientele, chronically ill, and you get admitted to the program if, one, you have a chronic illness and you are in an initial or unstable phase. You go in for 4 months of training, 4 months of follow-up, becoming stable. If you're not stable within 4 months, the program can be extended to 6 months. This was the average length of stay, was 4 months, okay? And once the patient is comfortable, then the equipment gets removed. The patient stays in link with the nurse, has the nurse's phone, has the nurse's email, can stay in contact with the nurse, and still remains rostered and registered with their network provider, right? The healthcare network that we set up. They are responsible and remain responsible for that patient in the home. There is no longer the technology in the home. Now, there are two issues here. The first one is the question, do you need that technology in the home after the training period and once you maintain the contact? And how much does the individual continue on their own, taking their own readings and marking them in their little book or marking them on their mobile apps, which are becoming more and more available? The cost of us getting more and more stations was prohibitive. So what we did is after 4 months, we moved on to another group of patients and another group of patients. We now at the East End have covered 500 patients, and we are continuing on with the rollover of that equipment. Question is, would those patients be interested in maintaining a link and maintaining that equipment on their own and paying for it themselves? The way you would pay on a monthly basis for your cell phone. So you pay a certain amount per month. Would there be a way that whoever was the supplier, in our particular case, the supplier is a mobile phone company, which decided that their market was healthcare and that they wanted to enter the healthcare sphere and have done so in a very significant way. Is there a way of offering that equipment to the individual or the individual's family and they maintaining it themselves? Because the public sector can't keep paying for it. I'm willing to provide the nursing connection. I'm willing to provide the place where the data goes to, as long as the family, if they want to, are willing to provide the technology. So what we decided to do is introduce a program of 1,000 stations throughout the island of Montreal. We'll divide those up into each of the 12 networks, and we'll begin a study over probably a 3-year period of time where we expect to be able to, with 1,000 pieces of equipment, roster 3,000 patients per year over a 3-year period, 9,000 patients in the study, and be able to demonstrate the impact on that clientele and be able to follow those clients over a 3-year period. So unfortunately, I don't have 31 million pounds as was introduced yesterday to do this. I sort of have to do it on my own dime, but we're going to try to get both the company that is concerned, TELUS, involved, our universities involved, possibly the federal government in a study like this, to try to demonstrate the impact. But the idea here is really not permanent long-term care installation of the equipment in the home. The only other piece that I think we should introduce, and you introduced in 206 here in England, which has probably been the least expensive and most successful, has been the call button that people wear around their neck. If I'm not mistaken, there's about 1.5 million people in England that now wear this particular device. Very low cost, but apparently has had tremendous success in reducing hospital utilization, in the security and the safety that people feel wearing or now having on their wrist. Nick was explaining this to me last evening, and I think this is probably one of the most significant things that I can bring back to the Montreal environment, because at a very low cost, I can hook up many more people into the continuum of care and create that level of security. So, as I said, 1,000 stations, island-wide coordination, the connection to the Oasis platform, very important to be able to connect this study, the data, the collection of information into the IS platform, such that each network, which has the patient registered, which has their medical data from the hospital, which has their data from the primary care environment, and will have this data from the home, all in the patient record, and be able to use that record for better patient management. So, in a last message, I always like to say this, when you're trying to manage change, don't keep trying to change things all the time. The issue here is that it's never the latest version, and hence we drive everybody crazy. So start somewhere, install something, use it, don't change it for a while, and then when something new comes along later, then you put it in place. Thank you very much for your attention.
So we've got the microphones again. There's a hand over here. David, just one quick question to you. You talked about the cost as being a significant issue. Can you unpack that a bit? Is it the cost of the technology, the ongoing costs of keeping the technology, or something else?
It really was the cost of the technology. There is the cost of the purchase of the technology in the first place, and I don't, and nor do my networks, want to be responsible for the technology, want to take care of the technology, want to repair it when it breaks, want to upgrade that technology or the software in that technology. We're not in that business. So what I need is to be able, for all intents and purposes, to rent that technology on a monthly basis. I'm very happy to pay, as I would suggest the family, in the way you pay for a mobile phone, so much per month, and that would be my responsibility. The cost of the nursing, the cost of the system, the cost of the home care. Oh, and I forgot to tell you the most significant result of this whole thing. Thanks for allowing me the choice and why it is cost effective. We were doing 12 visits per month, nursing visits per month, in the home of a patient for that 4-month period. We are now, with the technology during that 4-month period, doing 2.5 visits per month. So our calculation was simple. If it's 3 visits per month, to make it easy, that's saving 9 nursing visits, okay, 9 per patient per month. 9 nursing visits. A nurse does 6 visits a day, 30 visits a week, 120 visits a month. If saving the 9 visits divided into that, you see the number of nurses that we save right away, and simply on the cost saving of the nurses paid for the whole project.
But in terms of the cost you're talking about here, you are a big public purchaser of health and social care.
Right.
you ought to have a huge amount of leverage in your negotiation with some of the companies involved in this market to say, let's strike a deal here, if you do it across the whole of the province or indeed at a sub-provincial level.
Yes. The head of the TELUS company is here with me, wanted to come to the thing. He can attest to the leverage we have in our negotiation. So it was a very appropriate question. But I think there's an interest both for the company and for a large region like Montreal. I think it allows for the development of the product. It allows for demonstrating that the product is worthwhile, and then the company can go elsewhere throughout Canada and the world with that particular product. We just happen to hook up, in this particular stage of the game.
Sure. Okay, please.
Meiras from Israel. This was really exciting, and thanks for a wonderful lecture. 2 questions. First of all, what kind of incentives did you have to put in the system in order the caregivers to join in to this transforming of the system, first? Second, are there any obstacles for patients to join in, like money-wise?
I'll answer the second question first. There is no cost to the patient. All of care within the Canadian system and in Quebec is covered by universal health care. So there is no cost to the patient whatsoever. The first part, in terms of the professionals and their buy-in to the system, I think the home care nurses saw very quickly how this would really benefit them, and a lot of these home care nurses became the telehealth managers that now sit in their office with their bank of screens, collect the data, and they're in contact with each of the home care nurses out on the road, and basically dispatch them to the home when it's needed. They all realized right away the reduction in the number of visits, but they really saw the improvement in patient adherence to the program. The patient became, once they understood it, very comfortable, and that's why we think after the 4-month period, a lot of them or their family, the children of these elderly, will want to purchase the technology just simply to keep it going. Not that I don't think it'll be that expensive. Once it's at a large enough scale, it'll be quite feasible to do economically.
Okay, there was a lady whose hand was up in the middle, please. And if you have a question, we'll go to Gus next. We'll take one more after that, and that will take us through to coffee. Please, say who you are.
Sharani Rajapaksa from Serco. Firstly, an aside comment, Serco helped to implement the Boris Fixie bike, so I'll pass on your idea.
Excellent.
But my question is, in the UK, there is obviously commonly a fragmented approach to commissioning and providing health and social care. So I'm really keen to know what sort of, if any, were the key challenges that you came across in the HSSE in Montreal?
The issue for us when we integrated was really how do you get people who worked in the hospital for so many years, the physicians and the professionals, to really now accept that their role is also to go out to the community. So when we set up a diabetic chronic care management stage 2 environment, we no longer wanted that in the hospital. We wanted that in one of the primary care centers. So we said to the professionals and the physicians, are you ready to go out to the community? In the beginning there was a fair bit of resistance. I don't want to have to travel, I don't want to go away from the hospital, I'm comfortable here, this is where my family is, etc. Once we got them out into the community, and you needed a few physician champions to do this, the impact was tremendous. The patients like it, the primary care physicians like it, they don't have to go into the hospital. It's a 4 to 6 month training program in the community that diabetic patients go to learn how to do their insulin therapy in a much more significant way than just in the primary care physician's office. And the hospital is now only used for really serious tertiary intervention for those patients. But it was not easy in the beginning getting the professionals to accept that integration. Commissioning is difficult in the sense that you have multiple providers that are not connected, and the people working in those environments don't have a sense of belonging to their system or to their community in the same way, I think, that we've been able to achieve.
Okay, Gus.
I have a question for both speakers. And firstly, I would like to make a compliment. It was very fascinating to listen to you. I am trying to think how telemedicine is related to market competition. I see here in England more competition in the coming years. I myself, I'm Guus Schrijver, and I come from the Netherlands. There we see a lot of competition between hospitals, and then trying to implement something as ICU, what the Philips manager told us. It is fascinating, but I'm afraid that I have to have my dreams 25 years more.
For us in our environment, that competition just doesn't exist. There's a professional competition between the teaching hospitals to be more well known in which hospital will do most of the research. But in terms of providing care, there is no competition. And from the supplier, there are competition among the suppliers to provide the best price with the best product. But there aren't competition between the players. And because the decisions are made at the agency level, so at my authority, we will make the decision to where we go for the whole island of Montreal. It's much more focused. There isn't competition between the players.
I think it depends a bit what we mean by competitions. If I could just comment on that and then come over to Brian. I think the issue for me is if you have competition between fragmented providers, individual hospitals or whatever, then you could see lots of obstacles to applying some of the ideas we've been talking about. If on the other hand you say, well, might there be competition between more organized integrated systems, you could see actually that would lend itself very well to the early adoption of some of those because the benefit will come at the system level.
Correct. Yeah, competition is sort of an interesting thing in healthcare, and it has led to sort of outreach. If you take those integrated delivery networks, they're now networking in what I call the onesies and twosies, the independent hospitals, because they want those feeder patients coming in, and you might imagine that there's a clear benefit from that particular standpoint. We've been in discussions with Rotterdam for a while now, so it may not take 25 years. I'm cautiously optimistic.
Okay, and Brian, one final question for you. So what's coming over the horizon? You've given us a glimpse of the future based on what we know now, but if you speculate as to talking here in 5 years' time?
Well, I think that the problems that I alluded to there in my first 3 slides are only going to get magnified, and that we fundamentally need technology is only part of the solution. Sure. And one of the biggest challenges is workflow redesign, and we spend an inordinate amount of time not only developing enabling software, but then how do you change workflow? And that involves humans. If it was only software, it would be very easy. Changing human behavior, as this audience knows, is the biggest challenge out there, and people always talk about art and science and medicine. My approach as a physician was, science is the easy part, and I can actually write that into software. It's the art of getting patients to do the right thing that is the challenge, and there isn't a software package for that, at least not right now that I'm aware of. But so it's going to be, to everyone's point here, just tools to motivate patients, tools to engage patients, tools to figure out how to incentivize patients, even from a financial standpoint. I mean, they have to understand that everything they do has a cost, and if it costs them, then the carrot and the stick, you need both sometimes.
So just as we develop the technology, we shouldn't forget the human factor.
It's the biggest.
In all of that. Okay, we've got to coffee time. I apologise if you wanted to come in, but we've run out of time. But I'm sure both of our speakers will be happy to answer any questions you have as we go into coffee. Don't forget, upstairs in the Edwards room, there's coffee. There are cakes and things to eat, fruit as well, and there are exhibition spaces there which we would invite you to spend some time visiting. Please thank our 2 speakers finally as we go to